Thank you everyone to stay till the end this day. So my talk is talking about something different. It's about microcirculation and inflammatory response. And I have no conflict interest, but maybe I know many authors in my paper. In the paper, I will try to introduce. So what's microcirculation? If you have been here in the last section, you may know a lot about microcirculation. So in this section, I will try to say some pitfalls of microcirculation. So that's why we need to know microcirculation, and we will try to review some our finding and our friends group finding in New Zealand, and we both find microcirculation dysfunction in VA ECMO. And the last step is that actually we find some patients when they press the VA ECMO, actually they will get worse even after the 1 hour or 2 hours later. You will find the patient maybe improve, but later get worse too. So the future perspective, we maybe have to do more for the ECMO patient. In my hospital, we have almost about 115 to 200 ECMO patients every year. So one observed and then might be ECPR, and one observed was the VA ECMO, and one observed was the BB ECMO. So the pitfall microcirculation, first one is the CVP. As you can see, if we want to predict the fluid responsiveness, and the predict value is very low, and everybody knows this. And the pitfall of the MAP, as you can see, if you have a MAP of 65, and that could be the two situations. Just make it simple, right? So you can definitely find these two patients are different. One may be better, and in your right hand side, the patient might be need ECMO. Okay, so next step, even again, if we have a same MAP of 65, let's still have two situations. One is here and one is here. So maybe the patient in your right hand side maybe have a low hypovolemia. So actually, if you only see the number, you will miss many information behind the waveform. So what about the pitfall of the SpO2? Yeah, you can have many kind of SpO2. So maybe we'll feel very comfortable with the number of the 70%. But even under that, is that patient okay? It can still divide to different situations. Maybe if this is okay, but if this, you will be worried about something not good, and it can become worse. Yeah, the patient is under the VA ECMO, maybe also have the CAVH. So actually, don't just see the only one number. You have to find more information to determine the patient is good or not. So you may have seen this in my last talk. So I should make it quick. So if your patient have a blood pressure of 115/40, is that okay? Yeah, if in your left hand side, that may be okay. In your right hand side, if the patient with a high dose vasopressor, the perfuse, the small vessel density actually will be decreased. So you will hope your patient will at the right hand side and left hand side. And the right hand side, you have to be very careful. And now it's about the central venous oxygen saturation. How about 85? Seems higher than the normal range of 70. But as you can see, if you got a situation like a DIC, there will be many microthrombus in the microvessel. In that situation, actually in the black area, the cell around the vessel cannot extract oxygen. So that's why the area with the maybe double flow, they don't need to extract so many oxygen. So it should make it simple. If only one vessel is produced, so the tissue only need 15% of the oxygen. So actually, there are many people around this, and I may try to skip it. It's just say the heterogeneity during the sepsis. You have the heterogeneity problem, and if it gets severe, your glycocalyx layer will get destroyed. You will have a severe problem of a capillary leakage. So that's all about the pitfall of the daily we see the microcirculation. Actually, there are many pitfalls behind that. So how to measure the microcirculation today actually is very not so friendly. So for clinical practice, definitely no, but for research purpose, yes. So this is the second generation of the video microscope. It's called microscan. You can use it to measure the microcirculation status under the sublingual area. And now it come out with the third generation, it named as cytocam, and it become lighter, so easy to train. So actually, I think I'm the good friend of the ECMO team. So my ECMO team technician, they have tried to learn this. So my ECMO team good friend technician, they can use it to measure. So it means that it's easy. Even the ECMO team, the technician, they are easy to do this. But if they want to have perfect imagery, at least have to train in for 10 patients. Compared to the second generation, it may need maybe more than 30 or 50 to get familiar. So I think the third generation will be easier, but we are still looking for fourth generation because now the major problem is the software. The software now is not good for the third generation. The software now is good for the second generation, but still has some limitation. So about the microcirculation, maybe in 2007, that's the first consensus of how to evaluate the microcirculation, and we can make it simple. So when we talk about microcirculation, it's about small vessel with a diameter less than 20 micrometer, and you can easy and almost automated, you can get a total small vessel density. So that's called TSVD. And pervasive small vessel density is the major limitation today because you need the research nurse or research assistant to classify each vessel. So sometimes there will be hundreds of microvessels within one image. So that's the major limitation. It's like a semi-automated. When you classify every vessel, and then you can get a proportion of the pervasive small vessel. So today, actually, the PSVD and PPV actually is more related to prognosis. And we have the blood flow classification 0 to 3. As you can see, a cartoon is just represent if you have continuous flow, you can classify the vessel as 3. If you have absent flow or you think there's no flow, but you can see the vessel, and that's classified for 0. So for MFI or HI, MFI is just divide the image into 4 quarters, and you name each quarters by the classification of blood flow, like 3, 1, 1, 3, and the mean is the MFI, and the maximal MFI minus the minimal MFI and divide by the mean MFI, you will get an HI. So normally HI is as low as good. So if you want to learn more, there's the update consensus in 2018. And this time they are trying to focus on how to get a very good quality image of microcirculation. So I think these 2 references will be very helpful if you are interested in microcirculation research in the future. So the first publication was from the New Zealand group. Actually, we are doing the same study, but fortunately they published first. We a little bit delayed. So in their study, as you can see, the non-survival group, they have a lower TBD and have a lower PBD, and also PPV seems lower and FFI low. So everything, as you can image, the microcirculation is terrible bad in the non-survival group. Yes. And they also do a second study, and the second study is aimed for the weaning. If the patient is very good, if you try to decrease the ECMO flow, the microcirculation should be okay. If the patient is not so good, when you decrease the decrease the ECMO flow, the microcirculation may become worse. So very simple idea. So as you can see, the successful winning attempt is in the figure A, and the non-successful winning parameter is in your right-hand side. As you can see, in the figure A, most when you are decrease the ECMO flow, microcirculation didn't change a lot. But during your right-hand side, if the patient is not good or not able to win in the ECMO, the microcirculation will decrease after you decrease the ECMO blood flow. If I make it a little adjustment, it will be easy for you to understand. So maybe you can say, oh, the patient, the TBT is under 16, since no one could be winning. So sometimes if you have a very low TBT, you have to be careful. This patient may be not good to win in the ECMO now. If the patient have a very higher TBT and even you decrease the flow, sometimes the TBT will even increase. So you might have a question, why I decrease the ECMO flow, but the TBT will increase the microcirculation, even improve? The reason is that because I think it's easy to understand, because ECMO flow actually is increased after low of the heart. So good heart, if you decrease after low, sometimes it can perform better. So that's why even some patients, you decrease the ECMO flow, blood flow, the microcirculation can get improved. In that patient, I think they are winning too slow. Yeah, this our patient just very lucky because this is almost the same study and just twice the population, but very lucky we are still get accepted. In the beginning, we say, wow, they maybe not published because it's the second paper. So fortunately, we still got published. So almost the same finding. So if you can see, the lung survival was colored in green, and they have in the first is MAP, they have a lower mean artery pressure, and they have more requirement in the inotropic score, and the latter is higher. And in the lower three figures, you can see the microcirculation parameter. So in the lung survival group, the PSBD is lower, and the PPB is lower, and no doubt the MFI is lower. And next, we try to divide our patient into three groups, and the best 20%, and the middle 50%, and the worst 25%. So it will divide three groups. Maybe we just see the figure B. So as you can see, if your proportion of perfusion space so higher than 95%, it's almost normal. So the survival is very high. If it's the worst group, if you have a proportion of a perfusion space so less than 64%, as you can see, the survival is only 30%. So actually, now we understand your patient have a very bad microcirculation. The prognosis is very bad. So now we come to the inflammatory response to ECMO. I think maybe someone will classify it as like a reperfusion injury because your tissue may be in a low perfusion status for maybe 3 hours or even longer. So after that, you will have a pan-endothelial injury, and you will cause microcirculatory dysfunction definitely because all inflammatory will injure your endothelium, and it will cause multi-organ injury. So I think it's the very, maybe a study, a paper you can read, and you try to say why the ECMO can cause AKI, but I think it's too multi-organ, just for take this paper as an example. So they have many risk factors inside this, as you can see, and what I might try to say is that every pathway will maybe go through a microcirculation at the end, because once your microcirculation was destroyed, and you definitely will have different organ injury. So how to about deal with the inflammatory or even the reperfusion injury? I think the next step is that sometimes we just because AKI is easy to recognize. So sometimes we always use the CRT for AKI or to remove the toxin. But if we could go a step earlier, maybe we have to consider what about the cytokine absorption and how about the blood purification. And then maybe I think there are many ECMO experts here. So I think maybe we are trying to do something in advance to try to improve the patient's survival. So let's interest the paper. He tried to classify ECMO in different areas. And I'm saying, it's nice. Everyone is trying to do that. So maybe in the future, our ECMO patient could be extubated. And maybe the next, we have to try to use microcirculation, try to improve. Because now is the first step. We know bad microcirculation have bad prognosis. And next step is to try how to improve microcirculation. And then you ask, if we improve microcirculation, can we improve the survival? So there's still a long way to go. We just show some interesting maybe video. So in this patient, you can see the ECMO blood flow is almost 3, and the PSVD is 18.3. So everything seems okay. The mean artery is okay. So how about we try to increase the ECMO blood flow? We just increase 10%. But as you can see, the microcirculation not get better. So normally we think if we increase the ECMO blood flow, you will expect maybe, sorry about that. You will expect it increased microcirculation. But as we see maybe 5 minutes ago, actually you have to be careful because it increases the afterload. So if you increase the afterload, sometimes some fractured heart maybe not work so better. So it just take a simple. So in our pilot study, actually we find maybe 2 or 3 where when you increase ECMO blood flow, the microcirculation will increase. But some maybe 1 or 3, when you increase the ECMO blood flow, actually the microcirculation get worse. But I think it depends on different population. It's just a quick answer quick impression from our study. So you have to be careful when you increase ECMO flow. Sometimes the microcirculation didn't improve. And that's when we try to decrease the ECMO blood flow, what happened to the microcirculation? So there's another patient with ECMO flow at 3.17. And as you can see, if we decrease 10%, the microcirculation seems not change too much. But if you decrease more, you will find suddenly the microcirculation get worse suddenly. So in this patient, you have to wean in more slowly because it's not so good. Because normally, actually, we'll adjust maybe like 50% to test if the patient can wean off the ECMO. So it's just at the beginning. I think we have a long way to go. The second step is to try to find how to adjust the ECMO flow to maintain the optimal microcirculation. And next step, if we can improve microcirculation, could we improve the survival? Thank you. So I think in the future we have to keep the emphasis on both. We hope to maintain both good microcirculation and good macrocirculation at the same time. Thank you.